All right, y'all. Let's get started. Can anyone read this first case for me, please?
An 82-year-old female, hospital history of hypertension, 20 years smoking history of ischemic cardiomyopathy with an EF of 20%. Previous sent to the right start, presented to hospital for CHF exacerbation. On day 2 of hospitalization, she called for tachycardia with new onset chest pain, worsening shortness of breath. Her vital signs are respiratory 35, blood pressure 120/80. At that time, patient is tremulous and diaphoretic, but able to follow commands. Patient has diffuse crackles of the stem. What's your diagnosis of this rhythm and what is your?
All right. Does anyone want to read the EKG? Or just tell me generally what's going on? I'll give you a minute. It takes a little bit to read EKGs. Is it hard to see? Yeah. Damn it. I guess we'll start. Is this, you think this is regular, or is this a patient have a normal heart rate? No, right? It's pretty fast. Is this a regular or an irregular rhythm?
Regular.
Yeah, so I'll just give it to you. It's regular. So you had some calipers and you measured it out. All right, and then do you guys see any P waves? Anyone see any P waves on this? No, right? All right, so what do you guys think? Regular tachycardia without P waves, which one do you think it could be? Kind of narrows it down to 2 of them up there, right? So either A or B. Does anyone want to pick one? It's a guess, you know, no judgment here. You think A? And what makes? Ooh. So I think the big thing I'm trying to teach on this one is that, so you really don't know if it's AVRT or AVNRT. It's going to be kind of impossible, but the big clincher here is that this patient is is not stable, right? And the reason why I say this patient's not stable, this patient has new onset chest pain, as well as worsening new onset shortness of breath. This patient's having ischemic symptoms and also heart failure symptoms at the same time. So the thing that I was trying to hit here is that anytime someone is in an unstable tachyarrhythmia, no matter what, especially for interns, this is really big to know. Anytime anyone's in an unstable tachyarrhythmia, you're gonna have to use electricity in some way, right? So in this case, you would do a cardioversion. And I'm gonna try to teach about narrow complex, wide complex tachyarrhythmias today, and we'll kind of go through a little algorithm as we go through this, just so that you have a reproducible approach to narrow and wide complex tachyarrhythmias every time you see one of these patients. So really the first thing you do at all times when you approach one of these patients is you assess their stability. Things that will say that a patient's unstable is going to be new onset chest pain, new onset heart failure, as well as shock, and signs of end organ perfusion like altered mental status. So if you have any of those, you cardioversion. You don't even think about it. It's just kind of like the easy thing to do, right? And I think like cardioversion is really always in your back pocket whenever you approach someone with a tachyarrhythmia. You know, you can try to treat originally, but you know, if you think they could become unstable, always having the pads on. And if you fail at, you know, giving them vagal maneuvers, adenosine, beta blockers, calcium channel blockers, depending on what tachyarrhythmia is, it's always in your back pocket. So just always be ready for it. So I think that's a big thing I want to teach here. So the patient's stable. The next thing that you really want to do is you want to see if it's regular versus irregular, right? And we went through this patient, right? This patient is regular. Once you kind of narrow that down, you may need calipers in real life. You want to check the P waves. And really looking at the P waves is going to tell you, or at least help tell you, what kind of tachyarrhythmia this is. And that's going to narrow your differential, especially for regulars, is AVNRT, AVRT, they're going to look the same. Could this be atrial tachycardia? Or could this be regular sinus tachycardia and you have to treat the underlying cause? All right, so this one was You can't really see P waves. It's more likely to be AVRT, AVNRT. And, you know, if the patient is stable, you can use vagal maneuvers and adenosine, but if they're unstable, just remember, always use electricity. All right. Let us do the next question. Anyone want to read this?
Patients 59-year-old male, possible history of hypertension, lipidemia, COPD, poorly controlled diabetes, progressed to hospital with COPD exacerbation. Patient's telemetry shows an immediate jump from normal heart rate to heart rate below. At bedside, patients able to follow command, recognize chest pain, orthopedication, vital signs are on a significant curve, a blood pressure of 135/80, respiratory rate of 18, tachycardia. On physical exam, his end is marked for wheezing. Patient does not respond to vagal maneuvers or adenosine.
I'll give you guys a minute to look at it. So I think the first step is, do you guys think this patient is stable or unstable? Stable, right? So yeah, exactly. So this patient doesn't have new onset heart failure. This patient doesn't have chest pain. They're not altered. Their blood pressure's okay. All right, so you got stable, right? All right, who thinks this is a regular? Who think this is regular complex tachycardia? Good, yeah, so it is regular, right? And I'll just give that to you. So the next thing is looking at the P waves. Do you guys see P waves? And it's probably kind of hard to see from back there. I'll give to you, there are P waves. What's that? Yeah. So, and then the best ones to look for P waves is going to be in your inferior leads as well as V1. So here's a little P right here. Here's a little P right there. Right there. These P's, they're negative in the inferior leads. Do these P's look sinus to you? Maybe a bit of a leading question. Oh, did you really? What was the diagnosis? You wanted to, yes. So who thinks these are, so does anyone know what this rhythm is? So you gotta, so the P waves are all the same, but they are negative in your inferior leads. So they're non-sinus, meaning they're coming from a different part of the heart, and that different part of the heart is the first kind of name for this. Atrial tachycardia. Yes, this is going to be an atrial tachycardia. So I'm just going to go through real quick all of your regular complex tachycardias, okay? So the first one and one of the biggest one that you're going to see on the floor is AV-NRT. So what goes on with AV-NRT is that these patients, what happens is a lot of times this is triggered by an APC, like an APC somewhere in the atria, and it catches this bypass tract at the perfect time. So these patients have a slow pathway, so very, very slow, and they also have a fast pathway that comes back up, all right? So what happens is that the slow pathway actually has a quicker repolarization time, so it's able to be depolarized much more quickly. So these patients get an APC, and they catch this pathway right when the slow pathway is open to conduct, and the fast pathway is not open. So the APC comes in and catches it at the perfect timing, that electricity goes down the slow pathway, goes into your ventricles down the His-Purkinje system, creating this QRS. And then right by the time that it gets down there, this fast pathway is now repolarized. So it goes right back up the fast pathway, depolarizes the atria, and then it just gets this circuit that's right inside your AV node. So that's kind of why it looks the way it looks, right? So it's a narrow complex tachycardia. And a lot of times the P wave So the P wave is going to be very quick right after the QRS, right after QRS complex, because this moves back up the fast pathway and repolarizes the atria. So either the P wave is going to be, it's always going to be retrograde. So it's going to be negative in your inferior leads. But what can happen is that it's either right with the QRS complex or it's like immediately after. So the second one is going to be orthodromic AV arte. So these are patients who have a bypass tract, right? So basically what they have is normal repolarization of the Purkinje system. So you have good conduction, quick conduction, so a narrow QRS complex. There's no myocyte to myocyte. And then what happens is it actually goes back up the bypass tract, hits the atria again, and then that repolarizes the AV node. So you basically get this pathway that just keeps repolarizing itself through the bypass tract and right back to the AV node. And the thing that kind of helps you to discriminate AV NRT versus AV RT is actually where's the P wave. So for orthodromic AV RT, it has to go all the way down the Purkinje system into the myocardium and then back up this bypass tract, which takes a little bit of time, right? Which means that your P wave is going to be retrograde, and it's going to be it's usually going to be a little bit longer after your QRS complex. So usually like the cutoff is that the P wave, this retrograde P wave, right? Because it's going to be, the vector is going to be moving away from your inferior leads. 2, 3, and AVF, it's going to be retrograde and it's going to go back into the atria. If it's 100 milliseconds, that's the usual cutoff that favors AV RT versus AV NRT. But a lot of times this isn't really sensitive or specific, so it is somewhat difficult to tell whether it's AV NRT versus AV RT. And the next one is going to be focal atrial tachycardia. So this is like a little micro reentrant loop that is just somewhere in your atria that continues to fire and then overpaces the SA node, right? All right, so basically you just keep depolarizing this Purkinje system and you'll have a non-sinus P wave before your QRS complex right there. Usually this actually happens near the tricuspid annulus right here. So a lot of times this is going to be because the vector of electricity is moving away from 2, 3, and AVF. It's going to be negative in those leads, that P wave. So it looks like a non-sinus P wave. And the last one is going to be atrial flutter. So atrial flutter is a macro reentrant loop around the cavo, like the cavo tricuspid isthmus. And basically that loop just keeps going, creating those typical flutter waves that you see here. And then it's, depolarized the AV node, creating a usual tachycardia around 150. Can be regular if you have consistent conduction, like 3-to-1 conduction, but also can be somewhat irregular, like regularly irregular, if you have variable conduction as well. All right, so which one of these will be treated with adenosine and they'll go away, or vagal maneuvers and adenosine? Which ones respond to it? Yeah, so AV NRT, absolutely. And the reason why, the way I remember this is that this pathway involves the AV node, right? So adenosine acts in the AV node. Anything that the reentrant loop is involving the AV node is going to be completely respond to vagal maneuvers or adenosine. There's one other one. Which other one here does the reentrant loop involve the AV node? Yeah, AVRT, right? So this reentrant loop, see, it goes down, the ventricles come back up the bypass tract, but it involves the AV node, right? So you hit the AV node with a little adenosine, you're going to stop that. These ones doesn't. So ATAC sometimes can, but it usually doesn't. And why, right? It doesn't. This loop is a micro-reentrant loop in the atria, so it doesn't involve the AV node. The same thing with atrial flutter, right? The reentrant loop does not involve the AV node, so giving them adenosine is really not going to work. But it can help giving them adenosine just to see the underlying P waves, and that can help discriminate. All right. So that's kind of what I want to teach you about regular narrow complex tachycardia. The first thing you do is really check the P wave pattern. So if it's upright, gradual onset, you think sinus tach, and then you just kind of treat the cause, right? Sepsis, thyrotoxicosis, yada yada. So for AV RT, AV NRT, so there's going to be no P waves or retrograde after QRS. And the way you want to treat those are AVRT. The way you want to treat this is going to be vagal adenosine. And the last one is going to be, you're going to have a non-sinus P. It's going to be atrial tachycardia. And you can try vagal maneuvers. Adenosine is going to help you see the underlying rhythm. But mostly what's going to happen is you're going to need calcium channel blockers, beta blockers, right? You're going to have to slow down the heart in some way, slow down the inotropy of the heart. Or chronotropy, sorry. All right. I think this is our last question for narrow complex. Could someone read the case for me? This one's pretty hard.
Did you answer the last question?
Oh, did I? Did I just talk about that and not even say what it was? This was, yeah, atrial tachycardia, and the patient has already been treated with vagal maneuvers and adenosine, so it's not responsive to it. So in these patients, your choice would really be metoprolol or DILT. And since the patient is in a COPD exacerbation, wheezing, and doesn't really have underlying cardiac issues, doesn't have CAD or heart failure, in this case, you're really going to go with diltiazem. So, thank you. So C was the correct answer. All right. Cool. Actually, I'll read this one. 68-year-old male, 70-pack smoking history, comes to the hospital with a COPD exacerbation, treated with albuterol, tiotropium around the clock, as well as steroids and Zetrel. So you're called to the bedside because the patient's tachycardic, palpitations, but the patient denies any chest pain, worsening shortness of breath, or confusion. Blood pressure is 140/90. The patient's hypoxia, hypocarbia is improved with BiPAP. Potassium and mag are repleted, but this arrhythmia persists as well as palpitations. What would be the treatment? Immediate cardioversion, DILT, adenosine, modified Valsalva. Does anyone want to read this?
The rhythm looks pretty irregular. There's varying morphologies it looks like as well.
Nice.
Looks like it's sinus based on one upgoing, the P waves are upgoing and one downgoing. And there's narrow complex and zero complex.
Now you said there's P waves of varying morphology, right? Yeah. So which leads are the 2, 3, and AVF we're kind of looking at, right? And not all those P waves are the same. So we got a regular complex tachycardia with varying P waves, and a patient with like a COPD exacerbation. So what does that make you think of? But there's more than 3 morphologies, and it's irregular. So this would be a patient that has MAT. So really, when you see any irregular rhythm, just go through this real quickly. When you see any irregular rhythm, the 3 major ones that you think of in a patient who's tachycardic is going to be a flutter with variable conduction. So this will be regularly irregular, which means that some of the RR intervals will be the same as other RR intervals, where these 2 will be irregularly irregular. So we kind of want through a flutter, right, that macro reengine pathway. But if every 2 is conducted and then every 3 is conducted, you're going to see a rhythm that looks irregular, right? The next one is going to be atrial fibrillation. So this is probably the most common one that we're going to see. So this is just due to tons and tons of ectopic foci of depolarization in your atria that are just continuously firing. Every once in a while, they're going to get through the AV node, and then they're going to go down the Purkinje system, creating a narrow complex tachycardia tachycardia, that's going to be irregular. This one is going to be another irregular tachycardia, MAT. And what MAT is, this is like the typical presentation of it. It's a patient with a COPD exacerbation. They're getting treated with tiotropium albuterol. They may or may not have some electrolyte imbalances as well. And they're going to have 3 or more ectopic foci of depolarization in your atria, giving you basically firing at different times, giving you this irregular narrow complex tachycardia. So just going back to the question, this one's really tough because it's kind of hard to say, but there is, I think probably the best lead for it would probably be 2 down here. So you can see that not all these P waves look like each other. So that one doesn't look like that one, which doesn't really look like that one. Doesn't really look like that one, and doesn't look like that one at all. So which means that there's a couple different loci of depolarization that are happening in the atria, non-sinus, that are getting conducted down to the AV node. All right, so this patient, really what you're going to want to do is the patient's stable, right? So you don't need a cardiovert. It's a irregular complex tachycardia, so it's not going to be responsible. None of these are responsive to adenosine or valsalva maneuver, right? And then you're going to want to give 20 milligrams of IV dipped. So that is the correct answer here. And then just kind of going through this again, this is like the pathway that I kind of use just to think about it. So, the other things you got to think of in irregular complex tachycardia, kind of said it, flutter, right? So flutter, if you see flutter waves, especially if it's around 150, think of atrial flutter. If you see no P waves, or you see like fibrillation, think AFib. And if you think greater than 3 morphologies, think of MAT. And really all these, you're going to be treating with beta blocker, calcium channel blocker. In some cases, amiodarone DIG, especially the patients on like the hypotensive side and you're already cardioverted. They're a little bit more blood pressure neutral. But yeah, these are really what you're going to treat. So this is really my algorithm for going through a narrow complex tachycardia. I think the biggest thing is like looking at the P waves, but it's hard because I think it's always tough to see the P waves. Like, I don't know, I feel like every time I go to EKG, I'm just like looking for the P waves and I can never find them. So, but once you find them, I think it makes it much easier. And once you know if it's regular versus irregular, you really know how you're going to treat it, right? Regular, you're going to do adenosine vagal maneuvers, vagals first, then adenosine, and then irregular. You're really going to need to probably treat these patients with a beta blocker, calcium channel blocker, something that just slows down chronotropy. All right, so that kind of goes through narrow complex tachycardia. So those weren't hard enough. We're going to do wide complex tachycardia with the rest of the time. So we'll go through these, I think, kind of with each other because they're pretty difficult. Does anyone want to read the first question? I feel bad. All right. I'm glad you tried. I appreciate it. Like, I can't read this enough to go for it. You should just made up words. All right. So I'll read it for you. So 6-year-old female, no test, no history, went to clinic with 1 week of intermittent syncope. You happen to get crazy. You happen to get EKG during one of these episodes while she's in your office. She's denied chest pain, short of breath confusion, her blood pressure is fine. You don't have any previous EKGs, which you really want in a narrow and a wide complex tachycardia. So what do you think would be your diagnosis here? So I think really anytime looking at like a wide complex tachycardia, I'm just looking at it to see if I can prove VTAC, right? That's what I'm trying to do. I'm just saying, can I prove VTAC from looking at this EKG? You can't really disprove VTAC by looking at a wide complex tachycardia, but because all the things that you're going to be looking at are really not, they're specific, but they're not sensitive at all. So you're going to look at the criteria, and if the criteria aren't there, it doesn't help you that much because you can still be VTAC because a lot of those criteria they're looking at are just not that sensitive. All right. So what is anyone who thinks this is VTAC? Any reason, Julian, you think it's VTAC, or you just got that feeling?
I see like a capture beat.
Nice. Yes. So this is VTAC because you see capture beats, fusion beats, right? So I think the biggest thing that I'm going to teach here is, once again with VTAC, look for stability, right? This patient's obviously stable, no chest pain, no altered mental status, no hypertension, no shortness of breath. If they are unstable, you cardiovert, right? So we don't need to do that here. The thing that we look at next, or you can do this really in any way that you want to look at it, but one of the things that can help you is capture beats and fusion beats. So what are capture beats and fusion beats? What really they are, so if the patient has VTAC, they're having an ectopic pacer somewhere in their ventricular myocardium, making a very wide complex tachycardia, usually, depending on where it's from, because you're having complete myocyte to myocyte conduction in the ventricle, right? So what fusion beats and capture beats is that you have this VTAC going, it's going, and then especially with slower VTAC, what can happen is you actually get a sinus beat that beats out the VTAC, so it comes in, hits the AV node, goes down the Purkinje system. A capture beat is when you basically completely capture the your sinus node completely captures the AV node and completely goes down the Purkinje system, making like a P wave and then a complete narrow complex, one narrow complex QRS, and then it goes right back to VTAC. That's a capture beat. The fusion beat is a little different. So these kind of like they kind of meet each other in the myocardium, the sinus rhythm, as well as the VTAC, and it creates, and this is what you see here, it creates this kind of like Frankensteinian QRS complex, which isn't totally narrow, but it is more narrow than the other beats. So that's kind of what we see right here. So yeah, this one is going to be VTAC. And just going through the different causes of wide complex tachycardia. I put in a patient without a pacemaker because that's another cause of it, but like a patient with just native heart. First one is going to be VTAC, so complete myocyte to myocyte conduction. The electrical vector is going to be going basically back up towards the heart, which is going to help you a little bit as well. I'll tell you about that later. It's usually going to be pretty wide depending on where it comes. Sometimes it can come from like up here near the fascicle, and it can be a little bit more narrow, but a lot of times it's going to be more wide. The other ones, and this is what you're talking about. Anyone heard SVT with aberrancy? And you're like, well, I don't know what that is, but there's like an aberrancy somewhere. So what the aberrancy means is that, you know, these patients who are having SVT, they can have any type of SVT. All the ones that we just looked at, even just sinus tachycardia. But what's going on is that they have either a left bundle branch block or they have a right bundle branch block. Because they have one of those blocks, they're having myocyte to myocyte conduction, either in the LV or in the RV, and that's going to slow it down, making that QRS complex a little bit more wide. So that's kind of your SVT with aberrancy. And then the last one, and this is pretty uncommon, but I feel like I have to, you know, include it just to be comprehensive, is going to be antidromic AVRT. So we already went through orthodromic, right? Orthodromic goes down the Purkinje system, back up, does the opposite, right? It goes from atria, some sort of SVT, down your bypass tract, slowly depolarizes your ventricle with myocyte to myocyte conduction, and then it goes back up into the atria, creating this reentrant loop that's going to be wide complex because it's not going down the Purkinje system, right? It's going down your ventricle. So those are like the three things, and what we're trying to go through here is like, how do I try to prove that this is VTAC, right? So we did one of them so far, and then we'll do this case and we'll go through the other ones. How about that? There's a lot of them. If you did CCU, Dr. Mahafka loves teaching these, loves kind of ask any questions around about it. All right, I don't know if you guys could read this that well, so I'll read it out for you. 63-year-old male presents an ED with chest pain, shows a trope leak, lab showed trope leak and ST depression in the precordial leads. He is admitted to the hospital for NSTEMI, given aspirin 325, clopidogrel, torvastatin, metoprolol, heparin, started on a heparin drip. Oh, that was a bit of a mistake there. You're called overnight tachycardia on the monitor. You do not have any previous EKGs. What is your diagnosis? Does any brave soul want to go through this and see if they can prove that it's VT or not? Who thinks, with my raised hand, who thinks this is SVT with aberrancy? Who think this is VT? Do you want to tell us?
Sure. So it's a wide, regular tachycardia. I'm thinking VT. I usually start with week 1 and 2. Looks like QRS is down going in 1 and 2. It's probably a ventricular start to the complex. And then I look at the precordial leads, week 1 through week 6, and go for concordance. The precordial leads looks basically isoelectric in week 1 and week 2, and then probably down going through week 6.
Mm-hmm.
So that point's a little bit more towards week.
Nice. So absolutely, I agree with you. This is VT. And we'll go through, basically, we'll kind of use EKG to go through all the things that you look at to prove if something's VT or not. So one that we didn't touch on here, and the next one I usually go with is their AV dissociation. So what AV dissociation means is that, you know, in VT, you're having this depolarization in the ventricles, and basically the atria are doing whatever they want. Right, the sinus nodes may still be firing, but it's really not going to be associated at all with the ventricular fire. That's going to be different than an SVT with aberrancy. So an SVT is coming from the atria, going down the ventricle, and has some sort of aberrancy like left bundle, right bundle, but you're still going to have firing from the SA, like from either the SA node or the AV node. And that is going to create at least an association between the P waves, wherever they may be, depending on what type of SVT it is, and with the ventricle. So if you see AV dissociation, that proves that this patient has VT. This is going to be extremely hard for you guys to see from back there. I can barely see it from up here, but there is AV dissociation, and the best lead for it is going to be 2. So hard to look for. Like I said, like the hardest part I feel about EKG is finding the P waves. So you see a little tiny P right here. Little tiny P right here, right here, right here, right here. And you see that it's kind of marching out by the beat of its own drum. It's getting further and further away from this QRS complex here, which means that the ventricular rhythm and the sinus rhythm, or like basically the P waves, are completely dissociated. Right there, that alone proves that it's VT. The next one that we look at is going to be, you touched on this, is a wide QRS. So usually the cutoff's greater than 160. If it's a left bundle branch type, it can be greater than 100 from the initial deflection, upward deflection to the nadir as well, but this isn't a left bundle branch type, but you can look at how wide the QRS is. So just think about VT, right? It's going to be super, super slow because you're having complete myocyte to myocyte conduction through the ventricles, right? It's going to be very, very slow, which is going to widen your QRS. In comparison to one of the regular SVTs with aberrancy, so they're still going to have some His-Purkinje system that's working, right? And since some of the His-Purkinje system is working, it's going to be a little bit more narrow than a ventricular tachycardia. So that is another one that is helpful. So you got wide QRS greater than 160, you prove that it's VT. The next one we're going to look at here, as what you mentioned in 1 and 2. So these are huge. And I think this is like one of the easiest ways to prove that the patient has VT, is do they have something called extreme axis deviation. So you're looking at 1 and 2, right? Normal conduction of the heart is going to be, you know, from the SA node down into the AV node down the his Purkinje system. So, and the heart's probably a little bit more lopsided in the chest as it depicted here, but it should, the vector of electrical vector should be going to 1 and 2. There's really only one way it can go completely opposite of that, being negative in 1 and 2, and that's if it has a ventricular origin. So if it has a ventricular origin, you pretty much know, so sorry, if it's negative in 1 and 2, you know that it's a ventricular origin. It's complete extreme axis deviation. Can't really come from anywhere else in the heart other than the ventricle, just because of electrical vectors, right? So that's the next thing you look at, extreme axis. So negative in 1 and 2. So yes, then you prove VT. The other way you can look at that too, kind of similarly, is like, is it just positive in AVR? So initial positive with deflection in AVR pretty much tells you the same thing, right? Because just by looking at it, positive in AVR right here, that means it's also an extreme axis. So that's another thing you can look at to prove VT. And the last one is going to be concordance. So it's kind of tough. You look at it in the precordial leads, like Justin was saying, you know, here it's somewhat like ISO-ish, maybe a little more positive. This one gets a little more ISO. And then here it becomes more, the QRS complex becomes more negative. So there isn't concordance here, but if you see concordance, meaning that the QRS complexes are mostly are positive in all the precordial leads or negative in all the precordial leads, if they're concordant in their positivity or negativity, that can also help to prove VT. So concordance is the next one you look at. So those are the major ones that I look at to see if I can prove VT. And when I look at an EKG when they're wide complex tachycardia, I kind of go through that algorithm. I say fusion beats or capture beats, yes, it's VT. AV association, yes, it's probably VT. Wide QRS, VT. Extreme axis, VT. Concordance, VT. Like I said, these are all specific. They're not sensitive. So it still can be VT even if you don't have these things. The other one I wanted to talk about too is just looking at the patient, right? This dude is coming in with an end STEMI. He has, so he's at very, very high risk for getting VTAC as well. If someone has structural heart disease, it makes it much more likely that they have like a cardiac history if they're old. If they had ischemia before, it makes it much more likely that it's VTAC and not SVT with aberrancy. And one of the big things to also look at is like, can you look at a previous EKG? This can be really helpful, right? What if they had a left bundle branch before, and now they have like a left bundle branch type wide complex tachycardia that may help you prove that it is SVT with aberrancy. But you can get a right bundle branch block when you have a fast heart rhythm as well, just a rate-related right bundle. So it's not super, super helpful. Like if they don't have a previous bundle branch block, you can't just say that it's not SVT with aberrancy, but can help you. All right. Last question, I'll stop torturing you guys. I think I made these questions maybe a little bit too hard. So it's the last one. Patient's a 59-year-old female, past mental history of diverticulosis, then to the hospital with cough and productive sputum, feverish chills, dizziness, found to have a right lower lobe pneumonia. Get a call at 4 p.m. before sign out, the patient's heart rate just jumped up. Bedside, the patient's asymptomatic, no chest pain, shortness of breath, confusion. EKG is shown, you don't have a prior. What is going to be your treatment? So let's just go through the algorithm together. So does anyone see any fusion beats or capture beats? Yeah, so I see some no's. So yeah, there's none here, right? So we went through that one, no. Anyone see and you probably can't see it from back there, anyone see AV dissociation? I'll just say you looked very closely and you didn't see, you couldn't find any P waves. You didn't see it. So no AV dissociation. Is this QRS very wide? Like, do you think it's greater than 160? So measure right here. So I'll give you probably about 2 blocks, or probably about 3 blocks, right? So it's kind of about 120. So we can't use that. Does anyone see extreme axis deviation here? No, you say no. So there's no extreme axis deviation. And the last one, does anyone see concordance? No, yeah, there's no. Samip, I'm completely going off of your head shakes. No, so there's no concordance here. All right, so we think this could be maybe an SVT with aberrancy. We're not really sure though, right? We can completely rule out VTAC. The patient's pretty stable. What do you guys want to do? Where's the question? Who says they want to defibrillate? Who says they want the cardiovert? Patient's stable, right? We don't really need a cardiovert then. Though you may still cardiovert on VTAC. It's kind of like when someone has VT, if it's unstable VT, there's still kind of expert opinion whether you just immediate cardiovert or you try to give them amio. But this patient, we're not really sure if they have VT, right? So let's say no. Who wants to try vagal maneuvers and adenosine? All right, bold. And who wants to try metoprolol? No, you don't want to do metoprolol. So you really don't want to do metoprolol. The reason why is in someone, if this is VTAC, you can basically put them into shock if you give them metoprolol because they need that ionotropy of the ventricular contraction. So you're obviously going to be one of the cardiology fellow. But if you are unsure whether it's VT versus SVT with aberrancy, you can try vagal maneuvers and adenosine. It's not going to hurt someone that's in VTAC. So I just want you to remember that. So this patient, you tried a vagal maneuver, and you did the modified vagal, which is basically, so the standard vagal, you have the patient basically bear down for 15 seconds, and then that's it, right? Modified, and this is actually shown to work about 3 times better than the standard vagal maneuver, is you have the patient bear down for 15 seconds, and then you have them lay on their back, and you flip their feet up. And basically these 2 things together make this about 2 to 3 times more effective. Because vagal maneuvers really aren't that effective. I think it went from like 15% to like 35, 40%. So you try the modified vagal, and the patient goes back into sinus rhythm with a left bundle branch block. And you treated them, and they ended up having AV NRT with a left bundle. So cool. All right, I think that's all I got for you today. So just for the last one, so no, if you think it could be SVT, so expert consult, and it's okay to try vagal and adenosine. If you ever do this in real life, I did it one time, it's a great feeling. All right, anyone have any questions? All right, thank you.